So, good afternoon, everybody, and welcome to the first webinar of 2023 in the NOA Webinar series. Just a little bit of housekeeping before we kick off. So my name's Anne Hoey. I'm the Director of the National Orthopaedic Alliance. During the webinar today, all of the participants will be on mute. If you have any technical issues or you need any help or assistance with the webinar, the NOA team are in the background. If you use the chat button to contact them, and they will help you with any issues that you're having. Today we have Fallon, Kat, we have Claire, and we have Sadaf with us, so they're there to help you. As we go through the presentations, if you have any questions, there's a Q&A tab. If you put your questions in the Q&A tab, at the end of the presentations, we'll have some time for the presenters to answer your questions, and there'll be some discussion between the panel. The webinar is being recorded, and that recording will be available on the NOA website in the next sort of 2 or 3 days. And throughout the presentations, there may be some polls. If you just look out for the polls popping up and take part, they're really important to us, the polls, particularly the exit poll, because it helps us to understand if we're aiming our webinars to the right people, if we are doing the right topics. So any information, any feedback is really great for us. So, so why virtual wards? Why have we chosen NOA chosen virtual wards to be the topic for today's webinar? The NHS is facing unprecedented challenges at the moment. We've got winter pressures, industrial action, post-pandemic issues, massive challenges for the NHS. And virtual wards is currently really high on the government's agenda. A couple of weeks ago, Rishi Sunak chaired an NHS Recovery Summit. At number 10, he had the NHS England Chief Executive, Amanda Pritchard, and other senior leaders and senior clinicians from across the NHS. And the aim of that meeting was to turbocharge the recovery of the NHS post-pandemic. The following day, he was interviewed on BBC by Laura Kunsberg, and he brought up virtual wards. And he said virtual wards are a practical example of how we can ease some of the pressures. And he said virtual wards can make a difference right now. And in his subsequent press release, he said the NHS is rolling out virtual wards across England with an ambition to establish 40 or 50 wards beds per 100,000 population by December 2023. So high on his agenda. And Stephen Barclay updated Parliament last week by saying we'll capitalise on the incredible potential of virtual wards. And this was following a visit he made to Watford General Hospital, where he had some sort of personal experience of seeing how patients felt about, this makes me laugh, about early release, almost like they were getting sent out of prison, but early release from hospital, but having that that confidence that the medical supervision is still there, and that safety net is there, that if there are any issues or the condition changes, they will return to hospital straight away. He thinks that the scope to expand virtual wards to many more conditions than it's being used at, and many more hospitals in the coming months. So massive publicity about virtual wards, lots of talk at a high level about virtual wards. So as NOA is all about sharing best practice, sharing learning, we thought it was a really great opportunity to hold a webinar today with our panelists and share some experiences of pilots that have been run so far. So I mentioned that there'll be some polls. We're going to have a really quick opening poll now, and what we're trying to understand here is where you all are on your journey around virtual wards. Are you involved in them or not? So if you take a minute to answer the few questions, and then we'll share the results with you. Thank you. Oh, thank you, Fallon. Right, so quite a variety. That's brilliant. Thank you so much. That really helps us and the presenters when we're going through our presentations. Okay, so okay, so I'd like to introduce you now to our presenters. If my slides would turn over, we could get doing this. There we go. So I'd like to introduce you to our presenters, our panel today. We have Noel Kelly, who's the Medical Director at Spirit Health. We have Alex Gilbert, the Business Development Director at Huma, and Elizabeth Kendrick, who's the Medical Director at Hertfordshire Community Trust. This is a little running order for the day. So as you can see, there's time at the end for panel discussion and to answer your questions. And there will be, as I said earlier, an exit poll, which if you could complete for us would be fantastic. So Noel, if I can hand over to you.
Yeah, thank you very much. I'm just going to, I need to continue with my screen sharing. Did that come up okay? Yes?
Yeah.
Okay, hi. So a little bit of introduction here. My name's Dr. Noel Kelly. I'm the medical director since June 2020 with Spirit Health. Previously, I was a GP. I was a GP specialist in respiratory medicine. I was also associate medical director of a community mental health trust in Leicestershire as well as being a GP commissioner in the past. I'm going to talk today a little bit about the art of the possibilities. And specifically, I want to talk a little bit about how remote monitoring technology, not just ours, but remote monitoring technology can support the post-surgery elective orthopedic surgery. And I'm going to actually talk a little bit from perspective of our own remote patient monitoring technology, but also my experience as an expert patient having had a total knee replacement done in March 2022. A little bit about CliniTouch and a little bit about CliniTouch and Spirit. Spirit is a I'm getting lots of different stuff. My screen's gone a bit odd. My apologies. Nope. Spirit is a healthcare company first and foremost. We have a lot of experience in working with clinical services. We provide general practice care to 55,000 patients in the Midlands, as well as providing clinical services such as pulmonary rehabilitation, both digital and blended face-to-face, as well as a monitoring service also, looking after people with frailty over in Lincolnshire. So we come to it really from a clinical perspective rather than just a digital. As you can see, we are working across lots of different pathways. We are the major tech companies supporting virtual wards in Leicester and Rutland. We've got 16 pathways working across the whole of the health economy there, 9 of which are virtual wards. Interestingly, I think surgery has been slower to uptake on the benefits of virtual wards, but within Leicestershire, we're working with both colorectal and obstructive jaundice and have supported them in a virtual ward to get patients out of a hospital quicker. And this is just to say that So with 9 virtual wards, we've also got proven results. Over the last 10 years, we've worked in COPD and heart failure, COVID-19, and published data showing reduction in hospital admissions, readmissions, and also improvement in PROMs as well. We work across primary, secondary, and community care and integrate. We provide a wraparound service, so we're not just around giving the tech. My job in my clinical team is work directly with clinical teams to help design the clinical content they want that will help them make better decisions about how to manage patients safely within their own homes. How CliniTouch works, well, really, it's very simple. Patients through their own device or through an app complete question sets and vital signs into the system. It can also be prescribed specific educational modules, either in a written form or spoken word or in video. These question sets are a mixture of both objective and subjective clinical symptoms and signs. So you build a holistic approach to the way that we manage the patients in their own home. Then that is go through a system of generating algorithms that lie underneath it that generate a red, amber, or green risk rating that then a clinician can view on the dashboard. And this allows them to see where the patient is at in their recovery, but also to track them over a period of time. And it gives an opportunity for them then to interact with the patient either through video calls or in-app messaging, which are also available in the platform. And some of the platform features that we have, I think, can demonstrate by the number of different pathways we have. We've got a really flexible and adaptable approach, and we can really apply the technology to any clinical pathway. We have connected Bluetooth enabled medical devices, which are we're device agnostic, so we can source those for you, or you can provide those to you. We can track health trends over a period of time. And as I said before, we can interact with patients either through messaging or video calls on the platform. One of the things which I found really useful is our educational content. So the ability to set up a content which is prescribed for an individual patient. And then the clinician can also see what education that or training the patient has accessed through the clinical dashboard as well. We use this quite a lot with our POMI rehabilitation program within Staffordshire. We're interoperable with other systems like all health tech. We're both HL7 and fire compliant, and we've got interoperability presently going on in with systems in Lincolnshire and also in Leicestershire. I want to talk a little bit about me. This is me on the left side of the screen, and this is the offending joint, which is my right knee, which you can see has got the ubiquitous RO, black felt RO, so they didn't make a mistake on which knee to operate on. Really, I can only say that I had really good care from the surgeon and from the anaesthetist and the clinical staff. The wound healed it quite well to start with, and I was quite happy at that stage. However, I did have some complications. One of those was that I had quite bad hematoma on my right upper thigh due to the probably the size of my thigh. It was sort of partly my own fault, but also due to the tourniquet, and a lot of the pain was coming from them. That actually restricted my movement of my knee. And when I was seen a week after having been discharged from the hospital and saw the physio, I was only getting 66-degree bend or flexion in my knee. And that actually really made me have quite low mood over it and affected my recovery. And I was very fortunate to have a very good physiotherapist who worked with me and used actually technology as well, using a physio app to prescribe me digitally an exercise program that actually helped a lot. I also developed a wound infection about 4 weeks later, which really was a superficial wound infection, but had quite a lot of pus, I'm afraid, was quite nasty. I think the fact that I was a doctor myself, I knew how to treat that, but I'm sure that would have meant that if I hadn't been in that situation, I would have been seeking a lot more help from health services. On the left side of the screen, you will see my daily walk that I did, which was helped by my grandchildren on a number of occasions. I have had the permission to show this video by their father, who works in the Royal Orthopaedic Hospital as an anaesthetist. And what I also had a Garmin watch that I wore that I looked at my steps, and I increased my steps over a period of time, again, using digital technology to improve my outcomes. So in a total knee replacement, how could a digitally supported virtual ward have helped me? I think probably I could have got at a hospital sooner. I had quite a lot of pain that was coming from my leg. It wasn't really my knee. I think it was probably from my thigh. The pain relief wasn't really helping. I was using quite a lot of morphine when I was in the hospital, which caused the usual side effects of constipation. They wouldn't let me out until that had settled down. And I have to be honest, I did tell them a little white lie that everything was okay so I could get home. And because I knew that I could manage that better in my own home, which was the truth. My wife was a senior nurse and she helped me with that. Access to an exercise program, I really had a modified digital support with that because I had a physio app that I could use, and the expert really helped as well. I think the pain and reduced flexion due to the large hematoma really caused a lot of problems that affected my recovery and progress. I think I could have been monitored in my recovery in light of sort of the low mood I had. I could have probably had a stricter look at my exercise program, my engagement with that, my motivation. Certainly looking at wound infection and sepsis would have been something which is easier to monitor both in the post-operative and also in the recovery phase. My blood pressure was quite low in the hospital. I have mild hypertension, and knowing when I needed to restart my hypertension by monitoring blood pressure in the post and recovery period would have been useful as well. I think as well, carer support is something which we forget, how carers feel that they're not isolated with the patient themselves. I think it was quite hard on my wife at a time, especially when I had a bit of low mood about my progress and didn't feel I was making as much progress as I should. One of the things we have found when we have used digital technology is that patients feel more connected to their clinicians, and it's a kind of like a very soft benefit, but when they tend to feel more connected, then they feel less as if they're out on their own and feel more supported. I think with other patients as well, looking at thromboembolism and sepsis and clearly seeing that people are concordant with their VTE prophylaxis and taking the medications that they need, it's also something which a digital platform can help with. So I think, and some of these monitor patient post-op, some of these also relate to colorectal, looking at wellness and mood, looking at wound infection, symptoms of thromboembolism, sepsis and infection, also pain, location and intensity, so you can actively manage that, and obviously bowels and urinary issues as well. Specifically around orthopedics, and these are some of the ideas that I had having gone through this process, but obviously we would work with clinicians to decide what they wanted to monitor post-operatively, looking at the function of the joint and the ability and engagement and the gamification to exercise rehabilitation program, which sort of aligns and has a resonance with the rehab programs that we're already doing. Obviously, with some patients who have, even with elective, who are a little bit older, looking at their frailty markers and responding to those. We talked about VT prophylaxis, and obviously monitoring the patient's used to in the peri and post-operative period would be useful. I'm just going to finish there, but just to say, I ended up in hospital 3 days. I have a very close friend of mine in America who's having a knee operation next week, and they're going to be admitted at something like 7 in the morning. They'll be discharged at 6 in the evening, so they're not even staying overnight. And I think that shows the possibilities that we have of moving people quicker through and increasing capacity within our much needed bed space. Regarding his experience, I don't think he's getting a lot of digital support. So the support he's having post-operative is a lot of it's face-to-face in his own home, which isn't, I would say, particularly from a workforce perspective, isn't the most efficient. And actually using a digital support could have helped to reduce some of the workforce commitments that would be required. I'm really happy to take any questions that people have at the end of the presentations. Over to you, Anne.
Thank you so much. That was brilliant. Thanks a lot. If I can, there are one or two questions in the Q&A, but I think we'll leave until the end if that's okay with you, Noel. And I'd like to hand over now to Alex, if you're ready, Alex.
I am indeed. Thank you so much, Anne, and really enjoyed that talk, Noel. Hopefully you guys should be able to see my screen now with kind of just a strap line on Huma there. Amazing, perfect. So similarly to Noel, I'm going to start with a bit of a level set just around what Huma is and what we do. And I'll start with a bit of an introduction of myself. So hi, everybody. My name is Alex. I have been with the Huma team for the past 5.5 years. I joined as one of our first 10 employees and currently lead on anything and everything to do with the med tech space, which obviously means a lot of interaction in terms of surgical care specifically. But to give you a bit of background on Huma in general as an organization, so we are a digital health company headquartered in the UK. This is our 12th year of running now. We are around 500 or so in size with a few recent acquisitions. And initially 12 years ago, we very much started as a remote patient monitoring business, working with NHS hospitals to establish data collection outside of the four walls of the hospital. And through that kind of time, since 2011, we've expanded our services in a variety of different ways. So a lot of that has been from learnings that we've taken directly from interactions with hospital systems, as well as from partnerships with life sciences organizations, so pharmaceutical, biotechnology, and medical device companies. We tend to partner with these companies because they allow us a certain level of depth within a specific disease indication that complements the work that we do specifically in technology quite well. So for example, some of the points that I'll be showing you shortly, especially within orthopedics and the work that we're doing within establishing day case and virtual wards and monitoring for orthopedics is in partnership with Smith & Nephew as a brand, because they are providing us with a lot of the clinical input and therapeutic expertise that is allowing us to tailor digital solutions as a tech company within that specific field. We've also grown quite significantly in terms of the company itself. When I joined 5.5 years ago, it was 8 of us in a tiny little basement in Victoria. Since then, we've grown to, as I said, just over 500. And as a result of that, have also been able to raise a significant amount of funding that we reinvest quite heavily back into the product. And I'll go into more detail about what the product is, but I really wanted to kickstart speaking specifically about virtual wards for orthopedics and how we've kind of discovered that they're relevant and where we are kind of in terms of our thinking now. And actually, a lot of our thought process within this space began due to our partnership with Smith & Nephew, which began at the end of 2018. And initially, what we were planning on doing is just creating a prompts tool. So a tool that was going to be able to collect patient-reported outcomes, like the ones that you would for the National Joint Registry, like EQ5D and the Oxford Knee Score. But what we realized even back then, when virtual wards was not, I think, even a term that was being used, was through interactions with surgeons, with nurses, with operations and admin teams, as we were scoping the solution, was that there was a real gap for something that was going to simultaneously empower and engage the patient to take control of their care, while simultaneously providing information and intelligence and impact to the clinical and operational teams managing them. You know, at the moment, a lot of that was very episodic, and there needed to be a bit more continuity in order to really maximize the efficiencies that we were able to gather from the pathway. And so Smith & Nephew and us kind of embarked on a journey that is continuous and will hopefully, last quite a few years in the future, where we've been developing and augmenting the Huma solution specifically tailored to orthopedics by kind of implementing with different sites. And initially that was very focused on remote patient monitoring. In some instances now it's focused on virtual wards. Sometimes it's more pre-op, sometimes it's post-op, sometimes it's research. But those learnings have really led us to kind of having a well-developed program now where we're launched in over 15 different countries globally. So we're also kind of looking at this from a kind of cross-geographic lens and bringing learning in from other geographies. And we're also working across a large variety of different pathways. So not only kind of orthopedics and joint reconstruction, but also sports medicine, wound care. And again, trying to kind of bring those learnings back. And that learning element has been especially important for us. And that is something that I think is one element that I would like to impart to all of you as we kind of start to potentially look at virtual wards within ortho, is that it is all about continuous learning. There is a very big need to kind of not just implement a process and change things, but actually learn from that process as it is coming in and augment things as they go. But the key impact points that we wanted to have as a partnership, and especially within orthopedics, by either establishing virtual wards or kind of larger preoperative clinics or even kind of post-operative physio, are kind of outlined here. So we've had a lot of experience as an organization within digital health. We've worked with, I think, over 40 different trusts to date. We've treated, or we've had kind of over 1.8 million users of the platform. And so we've been able to borrow from other experiences to focus on, okay, what are the key points that we want to focus on for ortho? And those include enhancing clinical capacity. So during COVID, we were able to double clinical capacity for specifically COVID patients and also reduce mortality rate. So actually being able to implement a virtual ward solution within a COVID clinic actually was able to double the amount of people that individual staff members were then able to see and treat. Certainly being able to proactively avoid admissions, or readmissions in the case of surgery. So again, a lot of our work during COVID setting up virtual wards allowed us to showcase that we were able to, utilizing a digital solution, really kind of more proactive intelligence gathering, early identify patients that may be at risk of deterioration, and then impact those patients before they needed to kind of have that readmission. One of the elements that I think is hyper relevant for any NHS clinic at the moment is orthopedic waitlists. And that is really a big focus of what we're working on now. And I think the scope of virtual wards really is one that I think is quite firmly within that pre and just post-op phase, that perioperative phase. But we have seen clinics that are starting to think about, those that are waiting well and those that are on the wait list. And is there a solution in terms of offering light touch virtual wards to those in order to help them during that phase, especially for those patients that may be waiting up to 2 years or even above 2 years for a surgery? How do we continuously keep them engaged? How do we ensure that we are keeping those patients waiting well, and also potentially prioritizing patients for treatment? Is there an element of collecting information continuously that will allow us to prioritize our wait list in a more strategic manner? Of course, the ability of virtual, we actually are running a workshop today on day case surgery with a few orthopedic surgeons, just a few rooms down. One of the elements that we're certainly very keen on in terms of establishing virtual wards is the ability of virtual wards to reduce length of stay. So whether that is something that we can utilize to prompt more comfort around day case surgery, whether it is the ability to actually release patients to those virtual wards sooner rather than later, and as a result, monitor those same symptoms and vitals that we would monitor in hospital, but also reduction in length of stay is not, as virtual wards, is not only in data collection, it's also in increasing the comfort of the patient in order to be able to live within a virtual ward, for lack of a better word. And so a big portion of what we do is actually educating the patient and ensuring that within that postoperative piece, they understand that even though they are part of a virtual ward, they are not receiving care that is wildly different from the care that they would have within a non-virtual ward setting. And then finally, building capacity. So with ICSs such as ASNEFT and various others, we've been able to help them establish virtual wards with external remote monitoring hubs that essentially are bringing in a novel element of human capacity to help people manage those virtual wards. So I think each clinic is different. Each clinic will want to do things differently. And so our goal is to be able to, in some instances, provide that external capacity as well. But what the actual product is so the Huma platform consists of two main components. One is a patient-facing application, which you can see in front of you now. The other is a web-based dashboard. The importance of this, which is clinic-facing, which you'll see on the next slide. The importance of, and the reasoning behind why we've kind of set it up as an app and a web-based dashboard is to allow for those virtual wards to be obviously fully remote. So what happens for the patient is they receive an app, and our learning is that you have to guide the patient through their pathway. And so the first thing that the patient sees when they register for the solution, which you can see all the way on the left-hand side, is this kind of timeline of tasks. And what we've done is we've mapped out what that patient pathway looks like, including essentially that period that they spend in the virtual ward, when we want to collect certain data points, what educational content we want to provide to them. And we've then timed those activities in accordance with their surgery date. So that when a patient is either within a pre-op virtual ward or within a post-op virtual ward, they are immediately receiving the right information at the right time, and the data is being collected simultaneously. And we've had great feedback from that because patients feel like they're continuously being engaged with and know exactly what part of the process they're in. So there's no kind of lack of information. And the kinds of data points that they're getting asked to complete include patient-reported outcome measures like EQ5D and Oxford knee scores. We track their steps and their activity pre and post-op. That's a great kind of indicator of how they're potentially doing in the post-operative phase. We track their physiotherapy exercises. But probably the most important piece, and again, kind of the piece of knowledge that I would like to impart to everybody in setting up virtual wards, is the content. It is extremely important that you are educating your patients on what to expect in the pre, intra, and post-op phase. And actually, that is the main reason that they will want to engage with the digital solution in order to provide you with the information to set up virtual wards. Finally, the other essential element is being able to still have methodologies for your communication. So within kind of our version of the solution for orthopedics, we have built-in telemedicine, one-way messaging from the clinic to the patient, as well as a variety of other communication tools that ensure that should communication need to happen directly from the clinic to the patient in the virtual setting, that is something that we're able to do. Now, the other side, and some key learnings here. So the other side is a care team dashboard or a broader hospital team dashboard. This provides an insight into all of the information coming in from that individual patient's usage of the platform. So it allows the clinic to have an overview of their entire cohort. So those could be patients in their pre-op phase and their wait list. It could be patients in the post-op phase. Of course, in the pre-op phase, we have kind of relevant, and in the post-op phase, we have traffic lighting systems that allow them to then prioritize those individuals. A lot of those traffic lighting systems are what allowed us to increase capacity so highly when we were setting up our COVID virtual wards. And actually, I think within a virtual ward system within orthopedics is what is allowing you to potentially prioritize patients on the wait list to come in for surgery, as well as identify patients in the post-op period who may need more attention than others. And of course, kind of we also have the ability to connect to those health systems. I think that that is something that is essential. If you are looking at virtual ward solutions, if you're looking at kind of digital pathways, having something that is able to connect to your existing systems is really useful, if not essential. So that make sure that that's something that you're looking out for. And then finally, the telemedicine piece that I already mentioned on the app is, of course, driven by this portal side of things. So it allows you to schedule virtual visits, conduct those virtual visits, have a record of them, as well as interact with the patient in a variety of other ways as well. Now, where it gets interesting, especially from a virtual ward perspective. So I think we've been hearing a lot about virtual wards have kind of become this huge buzzword over the course of the past couple of months, and are being mentioned in various different meetings that we've gone through as the kind of solution. But realistically, I think we still have some work to do in terms of establishing exactly what a virtual ward even is within certain pathways. And I think that's really the question that we should be asking ourselves in orthopedics is, what do virtual wards mean for us? I think virtual wards are applicable in every indication, but what do they specifically mean in orthopedics? And so for a joint reconstruction, what we tend to do when we set up versions of Huma is we kind of map out the entire pathway. And so essentially, this is the virtual pathway, and the top line is the patient, which is the relevant one for this. The top line is the virtual pathway that a patient completes during that pre, intra, and post-operative phase. So a lot of the kind of tasks and a lot of the data collection and patient leaflet information and all of that is being kind of digitized and provided to the patient in a more timed manner to ensure continuous engagement in that pre, intra, and post-operative phase, whilst also simultaneously allowing for the nurse or the surgeon or the broader kind of administrative or operational team to receive the right data at the right point and interact with patients at the right point. And so from a virtual ward perspective, the way that you could view this is you could view it as just a virtual ward for pre-op, for example. You could have a pre-operative virtual ward where you're kind of keeping patients waiting well, allowing them to engage with physiotherapy exercises that are maybe keeping them active, prompting them with engagement information. You could have a virtual ward that is increasing your level of confidence with day case, which means that, you know, we're just kind of focused on that just peri-op piece and actually collecting some information pre-op and making sure that post-op we're collecting the right information as well. Or what I would recommend, and I think what usually tends to work best, is looking at these digital pathways or these virtual ward pathways as being something that is end-to-end. because in those instances, it's something where you are continuously engaging with the patient. You're making sure they're well prepared. You're making sure that the right data is being collected, but you're also engaging with them post-operatively to ensure that they're actually getting the benefit from both the virtual ward solution as well as more broadly from the interaction points that you want. Simultaneously, you're collecting the right insights and intelligence that you need in order to more proactively manage that patient's care. And the goal here, and I think what we're working towards, especially with some of the case studies that I'll get on into a second and kind of briefly cover before handing over, is not about increasing the level of work that a nurse or a surgeon or kind of another member of the team need. It's about slightly augmenting those operational pathways as well. That's very, very important. When we've been implementing our virtual ward solution in both orthopedics as well as any others, we've always had to look at, okay, what are your current operational pathways? How does this fit in? We should never be aiming to add on something more to do. We should always be aiming at slightly replacing something. And so the virtual ward solution that we have had for orthopedics is now gone live in a variety of different sites to date. But one of the ones that I think I quite enjoyed was the work that we did specifically during COVID-19 with one of our sites. And the main reason behind that is because virtual wards then became a necessity, right? You did not want the patient to be in a hospital during COVID-19 because they were at risk of infection for those that were kind of still doing surgery. And I think what was particularly exciting here is that it kind of prompted everybody to start thinking about virtual ward solutions in the way that maybe they had not been thinking about them before. And one of the sites that we initially partnered with, and a surgeon specifically, was able to utilize it to actually get patients to re-engage at a much higher rate than they would have done. So instead of having to bring the patient into clinic to then kind of restart kind of their approach to surgery, they're able to virtually connect with patients, virtually explain by use of the solution kind of what the pathway was going to be. That patient was then put on a kind of set list of tasks that were guiding them within that preoperative phase, fully virtually, no in-person interactions. They were able to do that pre-op assessment virtually with kind of one in-clinic visit. And then on the day of the operation, they came into their surgery with all of the data that was necessarily already complete. So the surgeon and the anesthetist and the broader team already had all of the information on file. And in the post-operative phase, when they were discharged, and they were discharged quite quickly, this allowed for that patient to actually be, again, kind of receiving the right information at the right time, and maybe having a higher level of confidence in the fact that their care was proceeding as normal. And some of the really great feedback that we had from this and other patients was, one, that following surgery, that the app was like having their own private digital doctor at home, which is exactly what you want to hear for a virtual ward, because that's what we're trying to do. And that despite having fewer face-to-face appointments, it actually made them feel more connected than ever, because they were having that continuous engagement rather than just kind of point-in-time engagement, even though that engagement was automatic and digital. So this is a solution that we're now kind of rolling out across UK commercial frameworks and are starting to partner with a large variety of different sites on. But the goal really for us in this partnership with Smith & Nephew, as well as the work that we do in orthopedics and the broader work that we do as an organization, is to create a world where every person lives their life to the fullest. And what that means specifically for virtual wards in orthopedics is that we're allowing for patients to be empowered and engaged to take control of their care, while simultaneously allowing clinical and operational and admin teams to maximize on efficiencies and actually utilize their time in the best way possible where necessary. Thank you so much for your time. I'm going to hand over to Anne to take us further. I think Anne may
Yeah, I
not
am. I'm
be
here, but
for
for some reason I can't make my video work. But thank you so much, Alex. Really, really useful. Lots of information in there. The questions are kind of mounting up now. So I'll hand over to Elizabeth. Elizabeth, are you okay? Have you got everything you need? Yeah, perfect. I'll leave it with you now.
Thank you very much. My name is Elizabeth Kendrick and I'm the Medical Director at Hertfordshire Community Trust. I'm hoping somebody's going to share my slides, but I'll start talking because I know we're a little bit behind. So we set up our post-operative trauma and orthopaedic patients. We did a pilot of this in December 2022. And we're now at the point where we're going to roll this out into standard practice. So I'm just going to talk a little bit. We built on the fact that we had already set up a very successful hospital at home service with virtual ward and virtual monitoring in the community during COVID, and we'd expanded that to include other conditions like COPD, heart failure, pneumonia, and some other conditions as well. So if I could just have the next slide, please. So we were on Sky News about hospital at home services, and this is the quote from one of the patients. I don't know anyone who likes being in hospital, so the sooner you get out, the better. This is actually one of the patients who was on our pilot who agreed to be videoed for Sky News. We can play the clip of the Sky News, but I think if we're running a little bit behind, so I might just let you watch that in your own time if you want to. So shall we move on? Oh, maybe, there we go. Okay, so the idea of the pilot was to understand the value of hospital at home remote monitoring and how they might be used for post-operative patient cohorts, and then use the findings from the pilot to inform scaling up of additional surgical pathways. So if we can get it right for people who are having post-op hip and knees, how can we move on to shoulders? How can we move on to trauma patients? How can we move on to different surgical specialities? And we're now moving into ENT and plastics as different surgical specialities to work with. So if we just go to the next one. So the benefits for patients, obviously, of hospital at home: avoid the risks associated with a stay in hospital. Patients tell us that they recover more comfortably in their own home environment, they're sleeping in their own bed, they're going to using their own shower, all of those things. We also, the benefits for the health and care system, we thought if we could earlier discharge patients, we could help address the theatre backlog and help support the elective recovery strategy by freeing up capacity to work through the waiting list. And it also improves flow through the hospital, and then therefore improves outcomes for emergency care patients as well. So if we just move on. I'm hoping we're going to move on.
The screen's just stuck.
There we go. So the patient cohort who we did this for were people having a total hip or total knee replacement. We excluded those who were really low risk because we didn't think we could reduce their length of stay. So we were looking at anaesthetic risk 2 and 3 in this pilot. They had to be aged 18 or over, residing in Hertfordshire. They had to have some kind of support at home. Now that didn't need to be somebody, we said it was best if they had somebody living with them at home, but it could be a family member who just came to stay in their post-operative period. And then we had nobody with dementia, but we have had patients on our ward with dementia in other conditions, and it's been their family members or carers who've entered the data for us and answered the questions. And in the pilot, there was no pre-existing comorbidities, which may impede the ability to monitor or report virtually. And the control group were patients who met the same inclusion criteria, had the same surgical procedures, but earlier in the pilot phase. So I think they're the November patients. So we looked at December patients, but they picked similar patients in November. So if we just move on to the next slide. So, the key performance indicators for the pilot were to understand the value the hospital at home remote monitoring system could bring for post-operative, as I said, to scale this up, to have high patient safety levels and high patient satisfaction levels. So if we just move on as well. So what did we do? So before implementation, we had to map the complete end-to-end pathway of what happened when you were on a post-operative orthopaedic ward after hip and knee surgery. So what did you get? What were the complications that you were worrying about it? What did orthopaedics want us to monitor? How many times a day did they want us to monitor it? How would we onboard the patients? What kind of patients would be involved? How are we going to ensure people get the same level of therapy and those kind of things? So we didn't want to provide a substandard hospital. We wanted this to be as good or even better than an inpatient stay. So then we compared what could be offered to align to the capabilities available via the existing hospital at home. And if I just explain a little bit about how our hospital at home system works, we have a central hub that monitors the patient, and it doesn't matter whether that patient's on the remote monitoring ward for if they've got pneumonia, if they're a post-op patient, if they're a COPD patient, if they're a heart failure patient. You are monitored by the same team, and then you have access to a consultant who will then to advise you if that is needed. So the team who monitor the patients, it's a nurse-led monitoring service, but we have GPs who also input into those patients. And the advantage of using GPs over other specialists is that the GPs can deal with if the patient develops a rash, if the patient gets a urinary tract infection, if something else happens to the patient, they will deal with all of those kind of things while they're on hospital at home. So we had to agree on what the clinical monitoring thresholds were like and what the escalation protocols were and how we would actually run that in real life. And we also had to develop a series of questionnaires that the patient was sent out, and they're very similar to the questionnaires that we saw in the first presentation. So basically we were asking people what their pain level was, what their wound, if there was any problems with their wound, if they were eating and drinking, if they'd taken their anticoagulation to prevent DVT, if they'd taken their pain medication. There were prompts sent to remind them to do their rehabilitation exercises. And there was also prompts asking them if they were concerned about anything or anything like that. And also if they'd been passing urine and opening their bowels and all of those kind of things regularly. And the patients were given, as part of the box, they're given a mobile phone as well. So through that mobile phone, they were also given access to all the joint school post-op rehabilitation videos to help them with their rehabilitation, which meant that we overcame the kind of health inequalities. If you don't have a mobile phone and you can't access data and things, the phone that we give them during this period has access to data, and you don't need to do that. And it also has an inbuilt video consultation mode. So our people in the hub could video with the patients and have a look at things without actually need for clinical visit. And we back this up as well with a face-to-face hospital at home team as well. So if somebody is in trouble and we think, oh, they need a blood test, or actually we want to give them IV antibiotics, we can do that as well. So we send out a patient to actually see the patient face to face. Really importantly, once the patient is transferred to hospital at home, the clinical accountability moves with the patient. So once they're on the hospital at home pathway, we are responsible for those patients as the provider of hospital at home, and they are in effect discharged from the acute hospital. We needed to make sure we got the consent right, and we did that before the patient had their anaesthetics to make sure that they weren't affected by the anaesthetic doing their consent. And the patient was presented with their box with their remote monitoring equipment in it in the hospital. As soon as they're discharged home, we work with a company called Doppler, and Doppler would phone them up and they would onboard the patient in effect to the virtual ward and teach them how to use the tech and all of those kind of things. And any problems with using the tech is dealt with by the technology company Doppler rather than being dealt with by clinical staff. We can just move on to the next slide. So we looked at 12 patients, undergone a total hip or knee replacement during September, October, or November. You can see the age range there and the male-female split and the type of surgeries. And this is how we kind of worked it out. If we just move on. On our system, if you flag any red flags, a hospital at home clinician would contact you to arrange further assessment, and if it required, a home visit can be arranged, as I said. So any of the red flags were if you hadn't opened your bowels, or you were reporting significant pain, or if you're reporting a problem with your wound, then it'd be possible for the doctor to be able to do a video consultation with you, or one of the nurses or one of the physios, depending on what you were reporting. And that team can then do a video consultation with you, and if necessary we can send out one of the nursing team or a physio to see you in your own home. So if we just move on. So this is our length of stay graphs for the control group from August, and then the pilot group in September, October and November. So you can see a 39% reduction in length of stay, and you can see the different levels about how we reduce this down. We were hoping that we'd be able to get to day case surgery or 1 day length of stay, and it didn't quite work out with that, but we hope as we get better with this and the orthopaedic surgeons become happier with this, we'll be able to get to a 0 or 1 day length of stay. So all monitoring red flags were consistent with expectations, and other patient cohorts on remote monitoring. We had one escalation to the orthopaedic registrar for suspected DVT. I don't really know why we did this, because we normally manage DVTs in the community. We have a DVT pathway which allows the patient to be managed without going to hospital, but because it was a pilot, they thought they ought to escalate it to the orthopaedic registrar. We had one patient escalation about how to carry out the physio exercises, and the physio was put in, and 3 of them required face-to-face home visits. We had one for a wound review, as the patient had been unable to take a successful photograph using the phone. One for a blood test, as the patient had fatty liver and had taken paracetamol, and there was concerns about the patient's LFT, so they needed to be rechecked. And then one for suspected DVT, which is the same one as above. And we do a point of care D-dimer and then arrange an ultrasound to assess patients for a DVT. They get a point of care D-dimer, a Wells score. If they're still at risk, they get an ultrasound as well. We got 9 patient responses from our survey, and 78% said it was good or very good. Of the 7 patients that DOCLA surveyed, 71% said that they were satisfied or very satisfied with the service that DOCLA was surveying them on. So if we just move on. So we showed an improvement in their reduced length of stay, positive feedback from the patients and their family, patient safety and satisfaction was maintained. We needed to improve the patient experience around provision of information and onboarding, because of the different juniors involved in orthopaedics and some change in staff and some change in how we did things. It didn't quite go as well as we would have hoped. And the idea is that once we've sorted that out, which we've done now, the pathways will be replicated across additional surgical specialities to support elective recovery. And there's no reason why we couldn't do it for shoulders, elbows, all of those things, if we were able to make the joint school rehabilitation pathways available so the patient can do their exercises. So if we just move on. Our pilots featured in NHS England's perioperative digital playbook, and you can read about it there. We call our service hospital at home, because we find that's much easier to explain to patients that they're having hospital level care but in their own home. But nationally this is referred to as virtual ward, and we use the terms interchangeably. I think that's, and I'm happy to take any questions. I think that's it. Don't think there's any more.
Brilliant. Thank you very much, Elizabeth. Thank you. That was brilliant. So we've had lots of questions, and I know there's been lots of answering questions going on in the background from Alex and Noel while Elizabeth was presenting. So if it's okay with you guys, we'll go to the questions. So the first one, and there's been a couple about this, and Alex, I know you've answered 1 or 2 of them, but it's about, what are your thoughts on virtual wards for elective routine orthopaedic patients, and would virtual wards be useful for any specific patient groups? And Noel, I think you'd like to come in on this one.
Yeah, I actually think you can apply digital support and virtual wards for actually any pathway. You know, we're doing things like hematology, oncology, colorectal, the CHUGS team at Leicester Royal Infirmary. I mean, I think sometimes we have to realize that the technology is there just as an enabler to connect with data that a clinician can look at from a patient perspective. The hardest bit of it is actually setting up the clinical model and actually the whole wraparound, the escalation, who's going to look, what's the inclusion, what's the exclusion.
Yeah.
So a lot of the work we do is work with clinicians around the clinical modeling and the SOP. So that's, and then we fit in around that the what information would be required to allow people to get out of hospital quicker. So I think it's, if I'm honest, I think it's adaptable to any pathway where you have elective or any surgical or actually any condition which requires people to admit it to hospital. If you can do it with frailty, which are complex comorbid patients, then you can really do it with anything, so long as you've got all that other pathways sorted out. So technology is an enabler, but it's all the other stuff around the clinical model that's really important.
Right, brilliant. And Alex, I know you've answered part of this in the answers, but have you got anything to add?
Yeah, absolutely. I mean, I would definitely agree with Noel. I think that virtual wards are applicable to I think almost any specialty. We've worked across over 20 different indications to date, and I think it's just differences in terms of the ways in which they're applied. And I would also agree with Noel that a lot of it is around a lot of what clinics currently do, especially clinical teams, is data collection. And data collection is not what anybody here who's a clinical team member or even ops team member should be doing. You should be looking at the information and being able to then utilize those insights to make decisions on navigating that individual's care. So why spend your time getting the patient to a weight scale and putting them on that weight scale and then not noting down what their weight is and then inputting it into a system? Well, you could just automate all of that, and then you just look at the weight and make a decision based off of it. So in that instance, especially as Noel was mentioning, the virtual wards are kind of super, super useful. Now, I think within orthopedics, with which ones I think they would be specifically valuable for, I think there's a lot of opportunity, I think, in hip specifically, mostly because I think that hip patients have such a kind of, and hopefully in most instances, quick and easy recovery that you can discharge them much quicker. They have a good kind of preoperative pathway that can be followed quite well from a virtual ward perspective. Day case surgery, I mean, as I said, we're having the discussion today whether, virtual wards are applicable to day case, because if it's a day case, you shouldn't have a ward at all post-operatively.
Yeah.
But I think if you're building up your confidence with kind of full day case, actually kind of day case surgeries, we have maybe 1 day post or 2 days post as a virtual ward solution is maybe a good way to get the kind of confidence of the trust up in terms of day case. And then I think outside of orthopedics and kind of in the broader realm of kind of orthopedic, sports med, etc., I think the sports medicine patients are great for virtual wards. I think most of them want to get home as soon as possible. And they follow physiotherapy quite well. So yeah, those are the main ones that I would see being applicable, but beyond what Noel already mentioned.
Thank you, Alex. And Elizabeth, having run a virtual ward or been part of this pilot of virtual wards for orthopedics, do you have anything to add?
No, not really. I think you can use virtual technology for almost any condition. The key is engaging the clinicians and getting the pathway right.
Yeah.
And our technology partner, Docla, we just change the questions that we ask depending on what we're actually looking at. So if we're looking at a patient with heart failure, we ask about ankle edema and breathlessness on lying flat and all of those kind of things. If we're looking at somebody with a post-op surgical wound, we ask questions about the wound and pain control and those kind of things.
Right. Brilliant. Thank you, the three of you. So there are 1 or 2 questions about overheads and costs and administrating virtual wards. Elizabeth, can we kick off with you? So so we have a central hub and we have a nurse who monitors our virtual ward patients, and we operate 7 days a week, 8 till 8, and the patients can phone us at any point during that time. As part of that virtual hub, we have we currently have 3 GPs on every day and 2 GPs on over the weekend, and we have 1 nurse who is monitoring the patients, and we have access to physio, but we run this as part of a larger hospital at home. So we've currently got 96 patients on our hospital at home scheme, and those people are looking after all of those patients. You need to have access to IT.
our Dockler, who are our technology partner, they integrate with System 1, which is our electronic patient record. So the observations get automatically now uploaded into the System 1 template, so we can see what's going on there. But we also run the Dockler system as well, so we can see the questionnaires and things, and we can do the videos through the Dockler system as well. So you need to have admin to be able to register the patients on the System 1. You need to have a technology partner to help you with, and you buy the licenses obviously for the technology. You need to have clinical staff to be able to react to the observations, and you need to have the ability to recontact the people if you run into problems and you need a consultant view of things. There is national money at the moment for virtual ward hospital at home, and we as a place have a business plan. At the moment we're on 90 something patients, I think, on our hospital at home, and we have to get to 204 by the end of this year, and we have a growth strategy to be able to do that. But all systems will have a virtual ward plan, because it's part of how we deal with pressure on the NHS, and everybody will be looking to do this. And my view is that they should be doing it across elective as well as emergency care to help with the recovery.
So Alec, have you anything to add in terms of admin? No.
I mean, I think in terms of and certainly not anything that's going to be to the detail that Elizabeth just said, but I will say that it's very much about kind of, with all of the virtual ward system that we've looked at, you have to look at the operational pathway and the resource allocation and how you're going to augment your resource allocation in order to allow for that virtual ward to come in. It's something that you just have to look at. You can't just drop a solution in and expect people to pick it up and kind of, you know, just do it because they feel like utilizing a novel solution. You know, nobody wants just a new piece of tech. It needs to replace another activity, and it needs to kind of be part of the entire process. The other option, you know, which I think some clinics are starting to, is actually bringing in external staffing to specifically focus on virtual wards. You know, that's a model that works well in the US. Having kind of a whole external team that is kind of specifically focused on virtual wards has been super useful. So there's a variety of different ways, but it is important to kind of think about those things at the very, very start of those conversations rather than later on.
Brilliant, thank you. There are 3 or 4 questions about length of stay and reduction in length of stay, impact on length of stay, but there's a specific question from James Murphy. So he says, when we talk about reduction in length of stay, presumably this is hospital length of stay. Has analysis been done to look at total length of stay, including time on virtual ward, which also requires NHS staffing resource? He feels it's important to understand the impact on the overall resource. So Alec, would you like to start us off?
Yeah, more than happy to. I think that's a really, really great question, James. I don't think that there is enough data, and I don't think that there has been enough research done on length of virtual ward stay, because I think we've been so focused on that kind of actual kind of, there is definitely data from individual trusts, but I don't think we've done kind of enough research to say this is, you know, kind of what the average stay is. I will say that establishing virtual wards means that we have to think about a ward differently, and we can think about a ward differently, right? So where, you know, your ward stay maybe 3 to 5 days for your surgery, actually your virtual ward stay could involve a lot less human resource, but be 15 days, because as a result, you know, all of the processes are automated, all of that data collection is automated, the interaction from the staff team is more so when something goes wrong rather than actually kind of continually going and checking in on you. So I don't think it's an immediate, it's not as an exact comparison in the sense that 5 to 5 days means that we're not having value, because actually, even if it is, those 5 days in a virtual ward will mean that there's less staffing resource being utilized and obviously less space being utilized. But I do think that it's a really good question. I'm interested to hear what Noel and Elizabeth will say, because I do think that we do need more data on understanding, you know, what that actual total length of stay with a virtual ward looks like.
No.
Yeah, well, most of the data we have on virtual wards is probably related to COVID-19 and the digital COVID-19 wards, which has been the whole kind of catalyst to move into other things. Very early in the virtual wards and the numbers to actually get really good evaluations are presently going on. But if we are to actually look at the COVID-19, and I have a health economist works with me, and we have shown consistently the net savings on a system-wide. So we had 310 patients that went through the COVID-19 in Leicestershire with a net saving. So comparing the cost to provide it in the community as to provide in the hospital, which for 310 patients was £525,000, which kind of reflects a little bit about that. We also tracked the number of people who needed to stay on the COVID-19. And in the community, the mean was about 14 days, and it varied from about 3 days up to 22 days. So those are really the only kind of evaluations we have. But I think as things become more apparent, we'll see that'll shake down on the data a little bit more. But as I said, the virtual wards, there's lots of areas which are behind the curve with virtual wards. So I think ask us this question in a year's time, we'll have more clarity around it.
Yeah. Elizabeth, you had some data in your presentation about length of stay.
Yeah, we've done quite a lot of work on length of stay. We've tried really hard to show that using technology and virtual ward doesn't necessarily increase people's length of stay. I would say that when you first start with a pilot, people are obviously going to be more cautious because they're just getting used to dealing with those types of patients. And what we've seen from our other pathways is that the length of stay does tend to go down. So our average length of stay for heart failure is 10 days, and our average length of stay for most other conditions is 7 days. And I think our average length of stay in the post-op pilot was 3-point-something days. We try and discharge patients at the same time as they would have been discharged from hospital. We normally add, so if your average length of stay for a total hip replacement, say, is 2.7, we would aim for a total length of stay of 3.7, because we add a day on for the fact that they're coming home normally. But obviously some people will stay a bit longer than that. So if you get a swollen leg and you need a DVT assessment, you're going to stay longer than that. If you, but that would be the same if you were in a hospital bed. So the idea is that we don't prolong somebody's, and NHS England have released a really useful bed modelling tool where you can calculate what your normal length of stay is. You can then look at how much your reduction in length of stay you would expect to achieve by doing part of your pathway virtually, and then you can calculate the savings for your system by doing that in terms of releasing staff and bed days in your acute hospital. So that's quite a useful tool to use in the kind of economic evaluation of this.
And that tool's available now, is it, Elizabeth?
It is, yes. Yeah. So all systems are using that at the moment to do their business cases for their virtual hospital to get the money, and wards to get the money from NHS England.
Brilliant, brilliant. Right, moving on, there are two questions here. One is about elderly patients with no knowledge or ability to manage digital systems, or not so elderly, you know, as are they ruled out of the virtual option? And the other question that I'd like to link with this is, how have the pre-admission and education pathways been managed, with personnel contacting and enabling patients to start the process pre-op? So, Alex.
Yeah, I was to start with the elderly patients element. So it's an interesting point. We get asked always, you know, how are elderly patients going to interact with a solution? And actually what we found is that, yes, although there is always a portion of patients, not necessarily tied to age, that will not be part of a virtual ward solution, because either they don't want to use their phone for that, or, you know, whatever it may be. We actually find that with elderly patients specifically, it's more about kind of education and engagement at the start of that kind of piece. And actually, if you educate elderly patients, you explain to them why they're utilizing this solution and actually spend some time on that. So for example, we do a variety of things like educational videos and leaflets and other things. Those patients tend to be the patients that are the most engaged. Those tend to be the patients that are completing all of their tasks every single time. Those are the patients that are reading all of the content. They don't suffer from digital fatigue. They don't have 500 different apps on their phone that are all kind of pinging them at various different times of the day. And there also is a higher level of respect for something that has been recommended by their clinic. You know, they, unlike maybe some of the younger generation, do not rely on Dr. Google first and then the actual clinic doctor second. They rely on the clinic doctor first. So if this doctor in the clinic has told them, you need to use this app, they will use the app and they will use it religiously. So if that education piece is done properly, then I think, you know, it usually will kind of lead to very, very high engagement on that side.
It's brilliant. Elizabeth, when I was asking the question, you were kind of shaking your head. So what's your experience been?
Yeah, so the oldest patient that we've put through hospital at home was 91, and he managed absolutely fine with the technology. Our technical partners talk them through how to use everything. We also have, so if you're unable to use the app, use the phone and type stuff in, we have the ability to Bluetooth from the devices to the phone to us. So you don't actually have to put it in. So we've had a blind patient through, for instance, who couldn't see any of the readings. And so we Bluetooth the information from the device through up to us. The absolute final resort, if you can't do it, is somebody from Doppler will phone on a daily basis to collect the readings if you can't do any of that. And they'll talk you through how to do all the stuff. We've also had patients with learning disabilities through as well, and we've had their carers who've inputted the data for them as well, or sometimes a family member has inputted the data. And actually, a lot of clinicians say to me, oh, the elderly can't do this, but I think that's quite unfair, because lots of elderly people are now very good at technology, particularly after COVID, and the fact that they use like FaceTime to keep in contact with their families during COVID and all of those kind of things.
Yeah.
We get over the digital poverty bit by giving people a phone that has the ability to video and update things. So you don't need to have your own phone with data to be able to do that.
Noel, did you want to add anything?
Yeah, well, we can be. We've somebody of the age of 104 who was on our system in the league tables. I think Doc Labs had somebody at 102 because I was in a meeting with them as well. So just, and the average age of people on our system is 77. Some of the things just to point out is that we're using this for frailty. There are also, you can have carer modules, so a carer can input on behalf of the patients as well. We have a care profile as well. I think one of the interesting things is we did some research in this is when you have really engaged clinicians, patients love it. When you have clinicians who don't really like it, guess what? Patients don't like it. It's so the human factors is sometimes it's not the patients themselves. Sometimes clinicians feel, well, they won't be able to do it. And a lot of it is around making the whole process simple for them and not overcomplicating the patient user interface as well, which we're really strives to do, which I'm sure everybody else does as well.
Yeah.
So there's a lot of those factors to think, but I think we underestimate. I mean, we had somebody of 84 in our COVID-19 ward who'd never used a smartphone. And at the end of it, they got their family to buy them a smartphone so they could FaceTime with them. So it can show you can push it out.
It's almost a byproduct. There are still lots of other questions, and if it's okay with you three, if I send those questions to you, you could put some answers together, and then for all the people who've attended, we'll make sure that those answers are on our website so you can see the answers to the questions. I've got to say, we have never had so many questions as we've had today. And actually our attendee base for this particular webinar was fantastic. So obviously, you know, a high profile, high interest webinar for us today. I'm going to just, if I can still do this, share my screen again. Let me see. Things share. I tell you what, I hope I never have to have virtual home wards. Okay, so as I say, this is our first webinar this year. We're still planning our next sort of sets of webinar. The only upcoming event we've got in our diaries at the moment is our annual members conference, which is on the 19th of October. You'll hear lots about that if you're a member of NOA. And on that, if you're not yet a member of NOA and you'd like to be, you've liked what you've heard today and what you've seen today, contact us at info@nhs.net. My team will be able to talk to you about opportunities for you to join and benefits of being a member. There's a QR code there if you've got a quick second to take a photograph of that. And then again, on virtual wards, there are other virtual ward events taking place. NHS England's virtual ward team are running a virtual wards community of practice on the 26th. And then on the 23rd of February, there's a virtual wards clinical summit. So I'd just like to take this opportunity to say again to Alex, Noel and Elizabeth, thank you so much for making time today. Fantastic presentations, lots of interest, and I hope we can work with you again to maybe get some updates and progress reports when this is a bit more prevalent in orthopaedics. That would be fantastic. And thank you so much to the NOA team in the background for doing all of the organisation. You will see our the recording on our website and the answers to the questions we didn't get round to today. So just finally, thank you again. And when you sign out, there will be a post-webinar exit poll. I encourage you to complete it. So thank you again for your time. Thanks, everybody.